devices. We use instrumentation and all sorts of supportive measures to support these patients while they are in the intensive care units. On top of the antibiotics which are regularly given to these patients, we also have antifungal prophylaxis in the form of fluconazole. And the problem with fluconazole dosing that we use as prophylaxis in the ICU admitted patients is that you use it at something like 100 milligrams once a day or twice a day. And both of these are wrong dosing as far as prophylaxis is concerned. We obviously need to not use antifungal prophylaxis as a regular measure for all our ICU admitted patients. And on top of that, we have very severe colonization by MDR gram negative bacteria, which gets easily passed on the hands of healthcare workers, along with the irrational antibiotic therapy, which is omnipresent in our intensive care units. Now, if you take a look and try and compare the gram negatives with the gram positives, there are far too many organisms on the gram negative side with diverse resistance mechanisms, and therefore it accounts for 75 to 80% of the infections that we see in our hospitals today. And the problem with all these are they are resistant to 3 to 5 classes of antibiotics, hence they are labeled as multi-drug resistant organisms. While you see fewer organisms, though we do have MRSA, we do have vancomycin resistant Enterococcus faecalis or FECM, but there are still fewer organisms with very specific resistance mechanisms on the gram positive side. And therefore they account just for about 25 to 30% of the infections, but in very specific settings. For example, in dialysis units, as well as in hemato-onco and bone marrow transplant recipients, our gram positive still account for a good majority of the infections that we see in those patients. Multi-drug resistant organisms are also encountered, and the spread is very, very fast. You have one patient with a vancomycin resistant enterococcus either colonizing or infecting that patient. By the time you have diagnosed it, you have at least about 3 to 4 patients flanking that index case who are already either colonized or infected with a vancomycin resistant enterococcus. And that is the problem with the gram positive organisms that are MDROs, which are multi-drug resistant. On the gram negative side, you still have a paucity of agents. We had meropenem, so therefore we had carbapenem resistant infections. Then we had these being treated with colistin. Then we had colistin resistant gram negatives. So therefore we have started using ceftazidime, avibactam plus aztreonam. But then the whole story stops over there. You don't have any more. Though of course we have cefiderocol, we have ceftolozane tazobactam, and we have many others which have come into the arena, but then not too many of them are available in India with us to combat our gram negative infections which are multi-drug resistant. So we do have a paucity of agents. There is a lack of newer agents which are still being tested in the pipeline, which are at various phases of clinical trials and which are yet to be available to mankind to treat these multi-drug resistant gram negative infections. And even if they are available in Western Europe and the Americas. They are not available to us to treat our patients here in India. You compare this with the gram positives, there are still a good number of agents which are available to treat these infections. And newer agents have been introduced in the last 10 years, and there is still some promise for some more to come. So the commonly encountered the gram positive infections that we see are MRSA topping the list. In fact, it's almost become endemic in India. It's no longer an epidemic or an outbreak. And combined with this is the VRE, the vancomycin resistant enterococcus. We have macrolide resistance in group A Streptococcus pyogenes, a high level aminoglycoside resistant phenotype that we see in enterococci, and some of the multi-drug resistant non-diphtheritic coryneiforms such as Corynebacterium jacquium, which is resistant to almost everything except vancomycin. On the other hand, if you look at the gram negatives, you have MDR Enterobacteriaceae, which is more appropriately called Enterobacteriales today. Acinetobacter baumannii calcoaceticus complex, or CRAB, which we call as carbapenem resistant Acinetobacter, and it is resistant to almost everything. Pseudomonas aeruginosa, which can be carbapenem resistant, Burkholderia capacea, Elizabeth kingi meningoseptica, Ralstonia picketi, And now we also have Stenotrophomonas maltophilia. Now, the last four, or the last three, which you see over here, Burkholderia, Elizabeth Kingia, Ralstonia, all of these are innately colistin resistant. And therefore, these are organisms which are also used as surrogate markers to when you want to evaluate what has been the amount of colistin use in our ICU. So obviously, the higher the number of isolations of these organisms, the more is the colistin use that you have in the ICU, and that is why this list is endless. So multi-drug resistant Enterobacteriaceae Pseudomonas Acinetobacter. There was a 2011 EARS NET project, and they found the multi-resistance to be on the rise. In 2016 or 17, there was a WHO document which talked about what are the problems with multi-drug resistant organisms, how do we manage individual patients, and what are the infection control precautions that we do, that we can take to combat these, to prevent the transmission of these organisms from one patient to another. But if you ask yourself this question, what are our rates for India? We do. I mean, we must admit, we must confess that we do not have a clear picture. And why don't we have a clear picture? That is because not too many studies are there. We try and report from single centers. So therefore, the size is very small. The number of isolates are also very small. There is a heterogeneity in patient population if we want to compare. Even if we say, yes, we will all come together, which we don't anyway, there is a heterogeneous patient population that we have to study. Infection versus colonization. What we have as case reports, what we have as single center studies are MRSAs, we have multi-drug resistant Klebsiellas and Acinetobacter from the respiratory tract. But then how clear are we that those are not colonizers and they are actually infecting the lung or the airways? There is never a proper clear picture of infection versus colonization. So therefore, the studies that dwell on blood culture or bloodstream infections with MDROs or with MDR gram negatives, those are few. Sterile body fluids which are infected or contaminated with MDR gram negatives, there are still fewer. So therefore, epidemiological studies are very, very few, far and few in between, because funding is far and few in between. So therefore, it is very difficult for us to get to know the ground facts in India. And that is why epidemiological studies are always restricted to acute care hospitals and probably the tertiary and the quaternary care hospitals. The problem is not about not having funding, not having major collection of data. The problem is it is very, very vital for this data to come in if you need to have better infection control practices in this country. Now, before we move ahead, I just wanted to dwell upon this. What do you mean by an epidemic outbreak, and what is meant by when we say this particular isolate has become endemic with us? Yes. So if there is an unusual increase, your baseline is very, very less, and suddenly there is a blast. There is a huge increase and upsurge in the number of cases which are either colonized or infected with an MDR, particular MDR gram negative, say a Klebsiella, an Acinetobacter, or a Stenotrophomonas, and so on, which is isolated from one particular ICU or a set of ICUs in a hospital, then we call it an epidemic outbreak. Whereas if your baseline, your bar itself is very, very high, and there is a constant challenge from new admissions and colonizations, that means the spike will not be so high, in which case the facility is said to be filled with a number of these cases, therefore contributing to very high antibiotic pressure. That is when we say that we are swamped, we have become endemic with a multi-drug resistant, say, Acinetobacter or a multi-drug resistant Klebsiella. So where do they come from? They can either be from the hospitals, they are acquired from hospitals. They could also be acquired from community, and that's what makes it a huge challenge, or from long-term facilities in the form of hospices and nursing homes. So the caveat is that the ones which come from the hospital merge with the ones that are already there in the and circulating in the community. as well as in the long term care facilities such as hospices and nursing homes. So, therefore, the distinction is very, very blurred. And this is a problem because there is a back and forth distribution between various modalities of care, whether it is a hospice or a nursing home versus the ones which go to the tertiary care hospitals and come back. All right. So it becomes extremely important to distinguish between this, but the distinction is just not possible. And therefore, we really don't know where they're actually coming from. But then they're circulating between hospitals, between the community, and some of the long term care facilities. What are the reservoirs that contribute to the spread of these multi drug resistant organisms? The enterobacterial spread on the hands of staff, and this includes not just nursing staff, it also includes doctor staff, the medical staff, right? They also get contaminated, you can also get them from contaminated equipment, and that accounts for large clones of these bacteria. And that's when you call it local clonal outbreaks of enterobacterials. Klebsiella pneumoniae, Acinetobacters, they all survive on the hands of healthcare workers. Enterobacteriaceae, or enterobacteriales as they are commonly called today, they colonize the gut, and then from there they get on to the other sites. So that's why if you have patients with diarrhea or an incontinence, that increases the risk. All right. So you have multi-drug resistant strains somehow are more set. They are more able to survive at these places. They move on to the hands of healthcare workers. They are better able to survive on the hands of healthcare workers. And that is how they move from one patient to another. Patients who are on pulmonary disease, patients who have got increased days of antibiotic use and colonization pressure, all of this contributes to a lot of transmission and spread of these multi-drug resistant organisms. There are some organisms, say for instance, a Cyanidobacter or even Serratia and Enterobacter, which survive both on moist surfaces as well as on dry surfaces, and also spread through contaminated medical products such as multi-dose vials, multi-dose medications, which are used particularly in the pediatric ICU and the neonatal ICU. And that is very, very vital for some of the multi-drug resistant organisms such as Enterobacter and Serratia species to transmit, to spread from one patient to another. Now, the transfer in long term facilities, how does this happen? I think I'll just spend half a minute a little more on this. You have a patient who is admitted to AIIMS Mangalagiri. All right. Now, this patient gets initially colonized and later infected while he or she is in the hospital. Then, after that, what happens is the gut gets colonized in these patients with the multi drug resistant Klebsiella, for instance. Now, this patient is discharged from AIIMS Mangalagiri, or they go home, or the other scenario is where they are no longer able to afford, say, a tertiary care hospital such as ours, all right, or an Andhra group of hospitals, for instance. And then these patients' relatives tell the doctors that fine, we will, further care we will take up in a smaller nursing home, which is more affordable to us, or we will take this patient home and we'll get him back when, if he gets worse, or if the condition deteriorates. So therefore, what happens is these patients go home, or they go to one of these nursing homes or an hospice, particularly cancer patients who are on palliative chemotherapy. Now, these patients get admitted in those places. Now, what happens is there is an orofecal transfer from one patient to the healthcare worker, from the healthcare worker who doesn't observe very good hand hygiene. It goes through the hands of healthcare workers to another susceptible patient who is not yet colonized with these gram negatives. Now, what happens is the breakdown of personal hygiene in patients who are demented or who are incontinent or both is even further. The risk of orophycal transfer is so much higher in these patients. Along with that, there is an abuse of antibiotics, which increases the selection pressure, both in the ICU as well as on the gut flora. Along with that, you have very high rates of urinary catheterization, Foley's indwelling catheter is introduced into these patients and they're just left over there for days and weeks and months together without anybody really caring to take that Foley's catheter out. In a tertiary care institute like yours or mine, there is still a infection control program which is fairly strict, which is stringent, and there people say yes. Once the urinary catheter has served its purpose, we are going to take it out. But then just imagine what happens in a nursing home or in a hospice. In these cases, there is no infection control program. Nurses are not trained to bring it to the notice of the doctors that this patient has been on an indwelling Foley's catheter for so long. Should we take it out? So this is the problem in long-term care facilities. Similarly, you also have MDR transfers when patients are at home from one person to another, and that is how you have MDR transfers from the community. In addition to that, just imagine you have, you want to fatten up your chicken, you want to fatten up your sheep, so that tomorrow they can be used as very good resources of meat and meat products or poultry products. So there is a veterinary use of antibiotics. Along with that, you have the use of manure because you want very huge sized cauliflowers and very huge sized vegetables growing in the form of organic foods. And therefore, there is an agricultural sewage use. And all that is used over there is basically fecal matter, which has been treated. And you use that as manure from these animals. And sometimes even human products are used as manure. And therefore, all these are doused and completely laced with multi-drug resistant organisms. So all these get onto the agricultural produce, they all get onto the meat and the poultry products, and therefore you have this spreading in the community. This happens more commonly in our part of the world rather than in Western Europe. Probably that's why we face the onslaught even more. In addition to that, you have wastewater systems and effluents from hospitals which get drained out. Like in Hyderabad, we have a Musi River. In Vijayawada, you have a Krishna. All right. So you have too much of influence from hospitals, from households, all of that. Where does it go? It goes into these water bodies. Along with that, you have an agricultural input with antibiotic associated meat and poultry products with a large reservoir of gram negatives. And we just undertook this in our hospital at Rainbow Children's. And what we did is we went and, even now we do this. We go stick a meropenem disc on all our fecal microbiology cultures. And I can tell you about 10 to 12% of our fecal microbiology cultures are colonized with multi-drug resistant organisms, particularly a carbapenem resistant Klebsiella or an E. coli or an Enterobacter. Now, this is the problem that you face in routine practice. When you go back and take a history, a good number of these, at least about 5 to 6% of these 10 to 12%, will not give you a history. They would say, we have come straight with this child from home without any contact with GP or with another hospital over the last 90 days. So if that is so, and you're going to admit these patients, and tomorrow you may have to operate on these patients, just imagine what is the kind of antibiotic selective pressure that you have in the ICUs. All right? Just take this call, Surendra. Now, this is just to give you a comparison of gram negatives, the enterobacterials, the Acinetobacter, and the Pseudomonas. Now, if you could take a look here, the enterobacterials go mainly through the hands of healthcare workers, particularly those healthcare workers where the hand hygiene is not very great. So that's a huge risk factor. Along with that, urinary canalization, gastrostomy tube, and NG tube, all of these are very important risk factors. On the other hand, if you look at Pseudomonas aeruginosa, this goes through a sink, a drain, wet surfaces, moist surfaces. All right. So this is very, very important. That is why if you take a swab or if you take a water sample or if you take a sample from your drains, from your sinks, hand wash basins, you're more likely to get Pseudomonas aeruginosa. This is one of the reasons why you get a lot of Pseudomonas from your dialysis unit, from your RO water system. they run a very high risk of getting colonized with Pseudomonas aeruginosa. Whereas if you look at Acinetobacter baumannii, it's not just moist and wet surfaces. They even get onto the bedside tables, dry surfaces, fomites, even the linen, which was used by the patient, the upholstery, the curtains, all of them get colonized with Acinetobacter. This is the reason why it becomes even more a challenge to get rid of Acinetobacter. One single crab patient, one single patient in the ICU who is either colonized or infected with an Acinetobacter is good enough to pass it on to many others. All right. So the polymyxins have been used for quite some time as alternatives for the treatment, but then polymyxin E or colistin and polymyxin B, these are the common ones which are used. But then it's recommended to use polymyxin B. That is because there are various commercial forms of colistin sulfate and cholestyramate sodium, and this cholestyramate sodium is a prodrug which on infusion, when you give it to a patient, it converts itself into colistin sulfate, and that is the active molecule which is bactericidal in action. Colistin resistance can either be chromosomally mediated resistance, which is majorly reported and believed, or it can be a plasmid mediated resistance, which was recently described, and that is dangerous because a plasmid can always transfer very, very fast and very rapidly from one source to another. Yes. Now, these are the interventions for infection control of MDROs that we can possibly think about. Hand hygiene tops the list, then followed by environmental cleaning and control, surveillance, detecting and typing of strains, isolating and segregating our patients, looking at our respiratory equipment more closely, and sensor taps, and so on. Hand carriage comes in when there is a contact with patients. If you go and touch bed railings of patients while doing rounds, with the showers, the shower heads which are there in patient areas, handling bed linen and curtains and even upholstery, medications to patients, particularly if you have multi-dose medications, or if or it is a very common practice for nursing staff to just sort of charge a syringe, remove the needle, and just leave it over there, and they would just go and push it into a vascular access which is available in patients, and that particular syringe gets colonized with multi-drug resistant gram negative. Or if you do not use gloves, if you don't wear gloves, and you just manipulate wound dressings in an area, all right, any contact with the patient for more than 5 minutes, there is a huge risk of passing on or transferring multi-drug resistant gram negatives. And which are the ones that are more commonly found? They persist longer, Klebsiella and the Acinetobacter species, as compared to E. coli and Pseudomonas aeruginosa. Very simple procedures. We just say, what is going to happen if I do this? I'm not running a risk of transferring organisms. Exactly, those are the simple procedures that could transfer organisms through the hands of healthcare workers. Remember, just because you put on gloves, it doesn't mean that you have obviated or absolved yourself of the risk. No, because in one study it was found hand contamination, despite proper gloves using, could be 4 to 5%. And that is the amount of hand contamination that can happen. And when do we normally transfer organisms? Is when we are entering a unit or leaving an ICU, or when we go and touch any surfaces and then we contaminate our hands and go and touch another surface, and that's when we transfer organisms. Also recommended, before and after patient contact, there must be hand hygiene. After contact with body fluids, mucous membranes, and non intact skin. After contact with patient's immediate environment, immediately after removing gloves. When you feel that, my hands are sterile, your hands are not sterile, because you are as much colonized with those multi-drug resistant organisms as a person who is not wearing gloves. So it's equally important to observe hand hygiene, go wash your hands before and after removing gloves. All right. Acinetobacter is very commonly found, and these are some of the preparations that we have. Now, the hand carriage is more with Acinetobacter, a little more than that with Klebsiella. and with Pseudomonas. That means Pseudomonas among this group, that means the non-fermenters like Acinetobacter or Alstonia, they are more prone for hand carriage as compared to Klebsiella, E. coli, Enterobacter. And definitely these are more at a higher risk as compared to Pseudomonas aeruginosa. Artificial fingernails, typical for Serratia infections. That means ladies, particularly, I don't know if gents also have artificial fingernails, but I know for sure that people in AP and Telangana have, I mean, even men wear jewelry with rings and bangles. I mean, you have bracelets in men, and these are definitely at a very high risk of getting colonized. That is because when you have so many rings and bangles and bracelets dangling from your wrists, the hand hygiene is going to be that much poorer. So therefore, all these are situations where you run a very high risk of transmitting multi-drug resistant organisms. Yes, alcoholic hand rubs may be protective, but then not when you enter a unit or when you leave a unit. At that time, you must necessarily hand wash. Alcoholic hand rubs are used when you move from one patient to another, or if you want to manipulate ventilator settings, particularly for the nursing staff. That is the time when you could definitely use alcoholic hand rubs. Contaminated clothing, particularly the ones below the waist, the pockets, and the sleeves, they are all sources of contamination. And it's very, very important to be aware of this, because when you're not aware, that is the time when there is a huge risk of transmitting these organisms from one patient to another. So, what is the impact if you have a very good and a very robust hand hygiene program? In an epidemic situation, it really works beautifully to reduce transmission. It doesn't mean that it doesn't work in an endemic situation. Uh, the amount of education and the amount of talking that one has to do, gathering small groups of healthcare workers to bring about some amount of reduction in the transmission of organisms. The work done has to be much more in an endemic situation in order to get small amounts of reductions as compared to an epidemic situation where you normally do not have these problems, but then when there is an outbreak, you just call that particular person. There is a focused strengthening of the hand hygiene program, and that is when you get a lot of facility. I mean, you get a huge reduction in the transmission of MDR organisms. Yes. Environmental cleaning, it's controversial, particularly with enterobacterials, whether environmental cleaning, if used as a sole measure, is it going to take care of your MDR GNBs? No, really, because multi-drug resistant gram negatives, particularly the enterobacterials, tend to persist much longer, particularly the Klebsiella pneumoniae strains. They persist much longer than a multi-drug resistant E. coli strain, and they persist despite the good cleaning that you're doing. All right. That is because there are huge reservoirs which you run a risk of leaving behind even when you do a lot of environmental cleaning. And the longest surviving organism is an Acinetobacter baumannii. And can you beat it? In one study, it was found that it is capable of surviving for almost 6 to 8 months on a dry surface. The same thing holds good when you don't clean your hand wash basins and sinks and so on. There is a huge risk of that particular area getting colonized with Pseudomonas aeruginosa. Similarly, respiratory equipment and hand wash basins. So, therefore, does it mean that you're going to go around sampling your environment as a routine? Definitely not recommended. If there is an unexplained outbreak which is unexplained, and you must go around looking in your environment as to what could be the reason for transmission or an outbreak of Pseudomonas or an outbreak of Acinetobacter or a Klebsiella, that is the time when you must do sampling of the environment. So, what are the choice of sites that you will sample or you will clean? Those which are likely to reflect cross contamination. You must definitely focus on work surfaces which are very close to patients, such as computer boards. Do not forget the bed rails and the surfaces which are touched very frequently, very close to the patient. Respiratory equipment. Why? Because gram negatives tend to colonize the respiratory equipment and they get washed into sink traps. So all these are extremely important, particularly if you're, if in the ICU, there is a procedure where they follow open suctioning as compared to closed suctioning. So the plastic tubing that goes into that bottle, the bottle itself, do not wait for the bottle to be half full with the respiratory secretions of the patient. One must have a time frame every 6 hours, every 8 hours, every 12 hours. That is the time when the bottle will be washed, it will be decontaminated. You will have hot water rinsing, and it will be kept for air drying before it is reused on the same patient, or still worse, on another patient. It is not recommended to use those bottles. It is better to throw them out and take another glass bottle. But then, even if they have to be reused on another patient, I think it's very, very important for them to be washed thoroughly, rinsed with hot water rinses, kept for air drying, and then used on another patient. Cleaning and infection control is very important, therefore, to halt any outbreaks due to CREs and crabs. Terminal disinfection due to with hypochlorite must be used. And when we talk about terminal disinfection, we also take down the curtains which were used to cordon off that particular patient in the ICU. Hydrogen peroxide vapor could be used as an adjunct for CREs and crabs. The frequency of cleaning has to be increased, particularly with high contact surfaces with CREs and crabs. And it's also equally very important for the housekeeping staff to be aware of how to prepare and store these cleaning solutions. So, therefore, epidemic situations very, very suited, particularly when you have an outbreak of an Acinetobacter in an intensive care unit. But then you may need to vacate units to facilitate cleaning. It must be consistent. There must be some amount of monitoring of these clean procedures. All right. In an endemic situation, you may not be able to use this as a sole measure, but then you could definitely combine it with very good and robust hand hygiene practices. What do you mean by isolating patient? It's basically based on principles of physically segregating those who are known to be colonized or infected with an organism of epidemiological importance, and separate out these patients from those who are not known to be colonized or infected. What are the ways and means by which you can isolate patient? You can either place one patient who is infected or colonized with an Acinetobacter or with a Klebsiella, place that patient with another patient who is also known to be colonized or infected with a gram negative, like a Klebsiella or an Acinetobacter. This is one way. Now, you can put them in a single room if you have the facility. It may be possible in AIIMS Mangalagiri, but then it may not be possible in Rainbow Children's Hospital for various reasons, starting from affordability to availability of such rooms and so on. Then, in such cases, what will you do? You will have to identify patients with the same pathogen, put them in the same room. You could have double shift rooms, you could have rooms with four beds and so on. That is what is called as cohorting at the end of the bay. But then it's equally a challenge. It's more of a challenge to identify staff nurses who are going to look after these patients in the same room. So they must have that they would have to don on full PPE, and that has to go on for a full 8 hour shift. And they must not mix with the nursing staff who are looking after patients in other rooms. Definitely not with those who are immunocompromised, particularly organ transplant recipients who may be there on the same floor or in an adjacent room. Yes. These are the components of contact isolation precautions. Very often we just say implement contact isolation precautions, but then without a clear understanding on our end as well as on the other end as to what are the components of contact isolation precautions. Gloves, gown, a disposable single use non critical equipment, enhanced hand hygiene, restrict the entry to other rooms, and restrict the entry of visitors. How will you restrict the entry of visitors? There are various ways and means. One is by educating visitors. Two, by prying away visitors or restricting their visiting timings to very, very small timings. Or you could put a charge on tell them that you must wear a gown, glove, and so on, and then put a charge to the PPE. Definitely nobody wants to pay, use PPE, go inside, just spend about 10 minutes and come out and pay 150 rupees or 200 rupees only for this. So that way you could restrict your visitor entry. You could create special isolation wards. You could separate out the rooms in the form of private rooms. En-suite facilities means you must have a toilet and a bathroom. Or you could cordon off and at the end of a ward bay, but you must also make sure that there is nursing staff available in the form of dedicated nursing staff. All right. So it's very important. Surveillance cultures for colonization of new patients, those who have not known to be colonized previously, that could act as a very good surrogate marker of efficacy of contact isolation precautions. Patients who are known to be colonized or infected, all that is fine. All this is perfectly fine. But then there are some issues with isolation. And this was reported. Anybody who is interested in reading this article even further could go to Journal of Hospital Infection in 2015. The adverse consequences was you will have curious friends and relatives coming in. Is my relative suffering from, say, HIV or from hepatitis B or something of that sort? So it is not very easy. It's easier said than done when you say implement contact isolation precautions. These same patients are not allowed to move out of their dungeon or their isolation for long periods of time, and that can lead to acute depression, anxiety. They can get angry, agitated, and this agitation increases with the number of days towards recovery from the primary illness. So the recommendations is if you have a CRE Klebsiella in an immunocompromised patient, definitely you must isolate that patient. A crab in the form of carbapenem resistant Acinetobacter baumannii calcoaceticus complex, we do not have a choice, definitely isolate them. Carbapenem and colistin resistant Pseudomonas aeruginosa, definitely yes. But then it's very important to have a flagging system so that at what point in time can you discharge these patients and take them out of isolation. And disposable gowns and gloves, protective eyewear, and so on is extremely important when you are isolating patients who are colonized or infected with multi-drug resistant enterobacterials, crabs in the form of carbapenem resistant Acinetobacter, and any ESBL or AMC producer. So it works very, very well in an epidemic situation because you're totally segregating the infected and colonized patients from those who are not infected or not colonized. But then, and the requirement is for a very short period of time when there is an epidemic outbreak versus an endemic situation where you may need to isolate far too many patients. In fact, one full hospital may have to be converted into an isolation bay, and that may not be possible. So this question is always asked, and it will linger with us. Will all this that you are trying to institute, will it drastically reduce colonization and infection rates with XDR gram negatives? And that is a debatable and a questionable point. So therefore, surveillance is when you go looking around, actively screening and taking cultures from patients. It will allow early identification of colonized patients for contact isolation so that you reduce the spread of multi-drug resistant gram negatives. When all will you do it? It can be applied when you're admitting patients or after admission, and it is not really evident on clinical specimens. So, who and when will you screen? Now, these are some of the important questions that are always asked to microbiology departments. When do you want to do active screening, and what is its role in infection control? So, you screen all those patients who have been recently on antibiotic therapy, those who are admitted to an ICU, those who have indwelling devices, who have very, very severe infections, particularly the ones who are organ transplant recipients, who are HIV positive, who are on high doses of steroids, and they are admitted to a patient, admitted to an ICU, and they are afflicted with these very severe multi-drug resistant organisms, and who are going to be transferred from this hospital to another, transferred from the hospital to an hospice or to a nursing home, and then there is going to be a prolonged stay, and they also are at increased risk of coming back to this hospital, right? Previous surgical patients who have recently undergone solid organ transplants or a hematopoietic stem cell or a bone marrow transplants, patients who have been transferred to the hospital on mechanical ventilation or indwelling urinary catheters, or if there is an epidemiological link to some of the specific cases. Do not screen staff. Please do not screen staff. Do not yield to this clinical pressure. Surgeons, particularly and anesthetists, would tell you to screen all staff, to screen all patients in their wards, and that is a sheer waste of resources and it is an exercise in futility. Conventional culture techniques, they need to be hastened up. Phenotypic tests are fairly good in our country, and or you could also use if it comes to doing active screening cultures on staff, just take a blood agar plate and ask them to go put their four fingers and some part of their fingers and the palm onto the culture plates. Close the culture plates, put them in incubation for, aerobic incubation at 35 to 37 degrees. And the next day, you could get a zoo of organisms as you see here. Yes, which are the sites that you definitely need to do a surveillance on: perianal and rectal swabs. And this is very sadly missed out many a times. Nose, throat, axilla, groin, draining wounds, any skin ulcers, all of these if you need to screen for LRT colonization, that is colonization of the lower respiratory tract, definitely you need to collect endotracheal secretions and sputum. How long will you hold all your culture plates? For a max of 48 hours at 37 degrees. And it's fairly good and okay to use blood agar, which is valid. And yes, you may need to predetermine the number of plates, others you will just be preparing media left, right, and center. It's equally important to know what you're screening for. It's not, I mean, you can't be going on identifying all the organisms which are there in all these plates. Yes. So if you're screening for, say, Candida auris, it's much better to use a Sabarot's agar plate rather than a blood agar plate, and pick up only those candidas, pick up only the organisms from the Sabarot's agar plate which look like candida, pick up only the candida, subculture them, and also see whether you're able to grow a Candida auris, speciate it to and type it to a Candida auris. What is the frequency with which you will do surveillance cultures? This is another thing. They say, there are various controversial, debatable, it's a controversial and a debatable point with no consensus on optimal timing and interval. But then the general dictum is at least do it once a week and continue this weekly surveillance till no new cases of colonized or infected patients are admitted to the hospital, which would suggest a cross contamination. It's equally very important not to do a surveillance unless you have very defined, well defined, and oiled infection control practices for a specific surveillance organism. And it's very important not to do undirected surveillance without an audit. So it's very, very important to be aware of these before you say, yes, I will do surveillance cultures. So it helps in an epidemic situation and it is less likely to help you out as a single source measure unless you just want to use it as a measure to guide your infection control program. And even then, it may not be very, very helpful. Yes. I'm going to leave you with just one or two slides on antimicrobial stewardship because this is a CME program on its own. But then it's very important for us to remember that each patient must be given a right drug, a right dose, and for the right duration. So it's very important to remember that prior antimicrobial exposure is a huge risk factor for colonization with MDR organisms, particularly those patients who've been on quinolones or third generation cephalosporins. So it is extremely important to have clinical antimicrobial stewardship and also practice diagnostic antimicrobial stewardship from the laboratory. It could encompass all of these, wherein you restrict the antibiotics that could be given by clinicians to patients, but then you may have to use justification for many of these. Antibiotic cycling is something that is also used. It again works very well in an epidemic outbreak situation, but then if you try using it in an endemic situation, yes, you may have to be very, very patient and use it for a prolonged period of time. Both implement both the clinical antibiotic stewardship as well as the diagnostic stewardship, and also have the clinical pharmacist as well as the infection control nurse on board, so that you have antibiotic cycling, you have some amount of antibiotic restriction before you are able to demonstrate some kind of falls in the rates of MDR organisms. Education and infrastructure is something which is extremely important in these patients. Educating healthcare workers, whether you are faced with with an epidemic outbreak, or whether you are sitting on a time bomb, on a ticking time bomb in an endemic situation, all of these education and infrastructure, talking to our healthcare workers, talking to patients' relatives, trying to restrict the number of antibiotics and implement infection control measures. All of these are very key to infection control, prevention of spread of organisms. I'm just going to leave you very, very briefly on MRSA, VRE, and MRSA is here to stay with us. It is resistant to multiple antibiotics, and these are some of the risk factors that you have for a methicillin resistant Staph aureus. There is a changing epidemiology with the introduction of community acquired MRSA, which comes from hospitalized patients. It mixes with those strains which are already circulating in the community. So therefore, you have CA-MRSA or community-acquired MRSA is generally, I mean, by the rule of the thumb, it is very difficult to define anything except by doing a SecMec gene cassette study. But then you could invariably look at a CA-MRSA, particularly when you have, I mean, when you grow methicillin resistant Staph aureus from patients with these kind of wounds or superficial and subcutaneous abscesses, and they are all drained out, and you get an MRSA on culture. It's very important to remember some of these points. Don't attempt decolonization if there is an active MRSA infection. First of all, it's very important to get rid of the MRSA and then attempt a decolonization. Remove all devices, foreign bodies, and treat all skin conditions before you attempt to decolonize a person or an area of MRSA. Topical treatments are used first before systemic antibiotics for a skin infection. Do not use rifampicin in India for decolonizing a patient of MRSA or a healthcare worker of MRSA. That is because rifampicin is still used as a major drug, as a wonder drug in India to treat tuberculosis. All right. So finally, we are always left with this question: is it cost effective to decolonize and monitor the same in India? In an epidemic situation, where you're faced with a vancomycin resistance, enterococcus faecium, or a fecalis, screen all patients near the index case, screen your fresh admissions, remove all the colonized and infected patients, put them in one particular cohort, and don't allow mixing of these patients with the rest of them who are still vulnerable, who are not colonized with vancomycin resistant enterococcus. Any diarrhea must also be tested for Clostridium difficile, and that is extremely important. Screening of staff for fecal carriage is really of no importance. Please do screen them for hand carriage, because that is how VRE spreads from one patient to another. So the final take-home messages, it's very, very important for us to be aware that we are actually living in a plethora amongst multi-drug resistant organisms. You have a lot of guidelines available from the WHO, from the CDC, from our Indian ICMR, and so on. Our problems remain ours, and we must seek solutions locally. So it's very, very important. Yes, you have a lot of guidelines. You take guidelines, but customize them to our setting. Don't try to put a guideline which is made in the United States of America to our Indian setting without even customizing them to our settings. That is because you're trying to look at measures which are recommended for the US. They are not measures recommended to stop transmission of organisms in India. So it's very important. to remember that one single measure may not do a whale of good for India. You must be able to combine measures and form a bundle for infection control, and that would help in most of our instances. Thank you so much. I'm stopping sharing, and if anybody has questions, then I would be extremely happy um, answering these.
Uh, Thank you so much, sir, for a very enriching and a very enlightening talk. And that's the first topic that we have had from your end. It's one of the most burning topics, and how the postgrad students and the residents should be playing the role in the future when there's so much of MDR bugs everywhere around in the environment and in the hospital settings, in the OPD settings, ICU settings. So they have to also realize that what critical role that they need to play as clinical microbiologists, and also that they need to understand why they really diagnostic postings, why they need to really differentiate between infection and colonization, because that is something that is very mind-boggling, especially in the respiratory isolates that we deal, that what to process and what not to process.
Yeah, yeah, that's true.
So that one thing is very important. That my one question from my end is that in one of the recent groups there were multiple discussions about the patient cohorting for isolation precautions. So once somebody labeled as an MRSA colonizer, should we really isolate him, or we have to first segregate that, okay, this is a crab infection, this is more likely to spread as compared to MRSA or VRE infection. So will isolation has to be done or not? That is one. And if we prioritize whether it has to be CRAB first, then CRE first, and then the gram positives.
Right. So the in an order, that's what in one of my slides I'd shown, in an order of I mean in a descending order, you take crab and Candida auris. These are two very important organisms, and VRE. So crab on the gram negative side, yeast Candida auris, and on the gram positive side, vancomycin resistant enterococcus, whether it's fecalis, faecium, whatever it may be. These are three organisms which we need to be very vigilant about. The minute you have one isolation of a carbapenem resistant Acinetobacter, a vancomycin resistant Enterococcus fecalis or faecium, and a Candida auris, which by definition is multi drug resistant, it is considered an outbreak. So that means you step up hand washing, you step up restricted visitor entry and staff entry, unnecessary staff entry, unnecessary healthcare workers getting into that room. Try and isolate the patient into one particular area where there is not too much of an entry and exit. You may have to even, patients who are colonized this way and who are isolated, even when they require radiological facilities like CT scan or an MRI or a chest X-ray and so on, we always take them either right in the morning or at the end of the day in the evening, after all the OP rush is over and after all the other patients have had their radiological imaging done. That is the time when you say, yes, now these colonized patients are going to be brought in, and after that, that is to be followed by a terminal cleaning in the radiological facility as well. So these are three very important organisms. You will always have CREs. CRE Klebsiella, CRE Enterobacter, CRE E. coli is bound to stay with us. You can't give so much of importance to them. Yes, if you have, say, a solid organ transplant recipient who has a bloodstream infection with a carbapenem resistant Klebsiella, by all means isolate them. But then crab, VRE, and Candida auris, that will take the pride of place when it comes to instituting infection control precautions very urgently, as compared to, and then the next in the list will be your CRE, Klebsiella, E. coli, Enterobacter. Third in the list will be MRSAs, say in an orthopedic infected joint infection, or if you have a CABG which has gone bad, a cluster of cases of CABG or a valve replacement, wherein you have post-operative infections due to MRSAs, say a mediastinitis or so on, those will get priority. And that is how you will be able to prioritize. Otherwise, you may have to convert your entire hospital into an isolation ward, and that is not possible.
Absolutely. So what we do is that whenever we are reporting any CRE isolate or a crab isolate, we always mention in the infection precautions that this crab is isolated, so it warrants isolation precautions for the patient, and also kind of a surveillance or a vigilance or around by the infection control team also.
True.
So yeah. So any questions from the residents? You are really all the answers there. You must ask questions, as many questions as possible. Any
I would
questions?
definitely call upon the residents.
Yeah.
Please make visits to the wards. Please make visits to the ICUs. Keep in contact all the time. You should be phoning people on the clinical side, talking to them, getting as much history as possible, and walk across at least once a day to some portal. I mean, you can, obviously in a place like AIIMS, you can't go to all the wards all the days, but then I mean, you could select your days and say Monday I'll do this, Tuesday I'm going to go here, Wednesday I'll do this, Thursday I'm going to go here. So NICU on one day, PICU on one day, your MICU on one day, surgical ICU on another day, immunocompromised wards and ICUs on another day. So if you sort of barricade or select out your days and say I'm going to distribute my infection control rounds on all these days, that's what helps. And when you go there, you would also do some amount of antimicrobial stewardship, get that information, what antibiotic each patient needs. That helps it. I mean, it makes it more fruitful. That is when you would learn and you would be able to help in daily patient care in a much better fashion. It's very
Yeah.
important for residents. Please don't stick to the lab. Don't just say, I'm just going to sit and put up antibiotic sensitivities and identify organisms. That even your senior technologists would be in a very, very good shape to do it. In fact, they may do it much better than you would. So it's very important for us as doctors to be intimately involved in patient care. It's very important.
So one question I think the residents might be hesitant to ask, but I'll ask because I have faced that those things during my first year and second year as residency. If you go to the wards, if you go to clinics as a first year PG or a second year PG with very less amount of knowledge and not much authority, and they check upon you that why are you coming or what authority is he carrying with him as a first year PG or second year PG, because they might check him that who are you, why are you here, like that. So in that case, how would a resident would deal with such situations?
Well, that empowerment, giving some amount of leverage to residents, particularly the junior ones. Senior ones, anyway, have cleared their MD, so they would walk around with a little bit more confidence. But
Exactly.
then the junior residents are the ones who are totally lost. And when they go to a ward, they're often jeered upon, or they are sort of teased, and people tell them, "Ah, ye culture report batao mere ko pehle," before you start talking about what we are doing. But then on the resident side, remember, when junior residents go to wards, first of all you must have a list of patients who are there in that ward. That's the first thing. The second thing is always go armed with answers to questions that may be asked. So write down who are the patients whom you're going to look for in the ward, and what cultures had come from those patients, and what is the microbiology answer for those. And then you go over there, you talk to those people and say, we have grown this from this, we have grown this from this. The minute you give them those answers, they stand up and start taking notice. The first day nobody will notice, the second day nobody will notice, but on the third day they would say, I mean, you were talking something about having isolated something from this particular patient. What were you saying? And that is when the conversation starts. And then you will reach a stage where you don't go. They would say, hey, why didn't you come yesterday? We missed you on the rounds.
That,
So when you reach that stage, the minute you hear that comment, you know that you have done at least 50% of your job.
yeah.
And that is when, after that, if you say, can we also do this for this particular patient? Can we isolate this patient? Can we do this infection control precautions? They will surely listen to you. They would surely listen to you. On the empowerment side, Sumit, what you could do is just pick up the phone, talk, liaise with the prof and head of medicine, of surgery, or pediatrics, and say that my residents would be coming. Could you please help them out?
Yeah,
Could
that
you
that we
please?
already done.
Yeah,
We
yeah,
already done, and
yeah,
what has happened that there is a stark difference when the first year or second year PG goes for prescription auditing. First of all, he has got not that amount of knowledge. But when I go over there, so if I'm standing in the
yeah,
bedside,
exactly.
there'll be 5 to 6 staff nurses who will come and surround me. Okay, if the head of the department or some prof or some faculty has come from microbiology and they are discussing a case, then let them be around. And I have got a very positive feedback. And I'm not talking about the antimicrobial stewardship team also, even the infection control team also. When they come, they get a very positive feedback, and the faculty comes over there.
Yes,
So they
yeah,
have questions. They have genuine questions and queries. That if I tell them that you are supposed to give this drug like that, so they ask why. Then they on their own they come, sir, why don't you take a session for us? Why don't you take a class for us? Why to
exactly.
give some kind of small
It's always much better when
yeah,
you go the first time with your junior residents who are still
exactly,
in their MD curriculum, and then introduce them and say that these are our people,
right,
and I may not be able to come day after tomorrow, but then they will surely come. Please help them out, and they will also give answers to your questions. It works both ways.
right, right.
They should also cooperate, but then the empowerment comes from the top, it percolates down, and the junior residents must go properly read and prepared, for
Exactly.
which you may need to spend some time in the evening going through your notes, going through your patients, and that helps because you will continue reading, you will go back, read up, and seek answers for some of the questions that come up. Those are the clinical questions which will be asked day in and day out, day in and day out, at all times.
Right. So, any questions? Yeah, Dr. Mohan is here.
Yeah,
He's the infection control officer. I think,
sure.
yeah.
Good afternoon, sir.
Hi, good afternoon. Yeah, I wasn't able to see you. I'm still not able to see you. Yeah, I can see some
Now,
part of
sir.
your face now. Yeah, that's better. That's better. Hi. So you're
So,
the infection control officer from microbiology.
yes, sir. I'm part of associate
Okay.
professor here as well as infection control officer.
Okay, great.
Uh,
Yes.
so it was almost like a full meal, sir. Like we have covered almost every aspect of MDROs.
Yeah.
So I had few practical related queries, like what we are implementing here. Some queries are there. If I
Sure,
can,
definitely. Go on.
before that, that question which Dr. Sumit sir had raised regarding the isolation protocols, na, sir. So recently, I had one of the presentation for which I had literature now. So in the past almost a decade or past 5 years, there are plenty of publications have come, especially in Journal of Hospital Infection or Lancet also, saying that the isolation protocol, especially contact isolation protocol for MRSA and VRE, it is highly questionable, and there is no evidence or no proof that it
Correct.
does the infections and things. So, but while mentioning about this, you had mentioned about VRE also in the top tier, along with CRE, like VRE,
That is
vancomycin
the. I mean, the only reason is see in an adult with VRE,
yes, sir.
you've seen this happen. I mean, by the time you get a blood culture positive and you isolate and identify a VRE, you would have also got blood cultures flagging of positive from two patients who are flanking this patient,
Okay.
which means the hand hygiene in the unit is not optimal. It needs to be strengthened, and definitely there is a transmission from this patient through the hands of healthcare workers to the other vulnerable patients. That is why VRE, I wouldn't say the same for MRSA, but then VRE is a very, very important organism, and probably it's the only organism which spreads very fast on the gram positive side.
And maybe because all those publications are from the Western side, like it's not our Indian study also, as you said,
Probably,
like
probably. We
customization of
should
those
be more
guidelines is also
careful when we interpret Western Europe data and North American data to Indian settings. This
right.
is what I said. That there are quite a few datas and guidelines and things like that available, but then how much you can use, what of that will you use and customize it to our setting? That customization never happens.
Right.
People say IDSA guideline says this, CDC guideline says this. Yes, it says, but then that is for the Americas. But then can you extrapolate everything of that guideline to the Indian setting? I doubt. I doubt very much.
Right, sir.
So
So
customization to our setting is very important. But then for that, you should know that guideline full.
correct.
You should have read it completely. you should be in a position, you must be, I mean, that is why junior residents will not be able to interpret it. That is because they haven't attained that degree of maturity. Whereas we, being faculty, being consultants, we should have some degree of maturity to say, this much I would take, the rest appears a little questionable. And if you look at recommendations, they would say strong recommendation but very weak evidence.
Evidence.
Now it is you'll have to take all such recommendations with huge heaps of salt, not just a pinch of salt, because anything which is a strong recommendation not supported by a good amount of evidence is something which is like, I feel, you feel, so therefore it should be there. You understand?
Yes.
So it is very important for us to be aware of these things when you're trying to customize Western European guidelines, ECMID guidelines, and IDSA guidelines to the Indian setting. It's so very important.
Right, sir. So that is one thing. Another thing is about the practical utility of hydrogen peroxide vapor, sir. Like one of your slides while mentioning it for CRE, hydrogen peroxide vapor to be used. Did you mention it by for fumigation or cleaning, sir? Or how was it?
It was only for surface cleaning.
Surface cleaning.
Surface cleaning and some amount of fogging.
Okay.
That's about all. I mean, very restricted fogging.
Okay.
Yeah, because fogging and fumigation is no longer recommended. One for the ICUs, two even for operation theater complexes. We don't do anything like that.
Right, sir. And another thing is about hypochlorite use. Like for terminal cleaning, hypochlorite is supposed to be used. Like somehow in our institute, we are not able to use hypochlorite as such. Only during the COVID time it was used. Right now, even in the policy, what we had made was like in high risk areas, high level disinfectants, like probably or aldehydes or hydrogen peroxide.
Bacillocid cleaning.
That's what we are using, sir.
Important.
And
yeah,
in
bacillol or bacillocid cleaning is extremely important. And you need to, I mean, if it is a high risk area, like an ICU, an operation theater, solid organ transplant units,
yes.
Bone marrow transplant units, in all these places, one needs to clean 3 times in a day.
Mm-hmm.
Not just twice a day, not just once in the morning and once in the night or something. You need to clean 3 times in a day. That is very important.
Yes, sir. In other patient care areas like OPD or in a general ward, like do we need disinfectants like hypochlorite or even Lysol or something is sufficient? Like
Lysol should be okay for normal OPD areas.
Okay.
But then it also depends upon if you're running, say, a transplant OPD.
Based on the patients also.
The other thing is your transplant patient, say a liver transplant recipient or a kidney transplant recipient, is that person allowed to mix with the rest of the crowd? Okay, you can't have a common OPD and say in that I will also have one patient on high doses of steroids. I'll have one inflammatory bowel disease, say Crohn's or an ulcerative colitis, who is on prednisolone in high doses. I'll have a solid organ transplant, and I will also have a bronchial asthmatic who's coughing away like nobody's business, or a COPD, chain smoker, pink, blue bloaters and pink puffers, and they come in with infectious exacerbation of an acute respiratory infection. Obviously, they will give pneumococcus to this solid organ transplant recipient. So it depends upon how you're trying to organize your OPD, your outpatients. That is important.
Right. And where does this hypochlorite come in, sir? Now, like for a high level area, we thought about bacillocid and things. And for patient OPD and all, we are talking about the low level disinfectants. Like
Terminal cleaning is always best done with sodium hypochlorite.
Okay. Right, sir. One more important thing is here, sir. Like
go on. I have no problems. Go on.
Just yesterday we got a call from one of the surgeons, like saying that for central line, after that insertion site, we put the tegadam on top of it to cover that site. Transparent.
It's a transparent look-through dressing. Yes.
Yeah. After that, that line goes, and then the ports are there. That line they wanted to cover with some sheet cloth kind of thing. They are covering that line.
Why?
Is it needed?
Why?
I don't know from where he had
Ask
got this
them,
idea.
ask them, why do you want to use a cloth over there when you
Uh-huh.
already have a tegaderm dressing settling the line properly?
Yes, sir.
Why do you need a tegaderm dressing? Why do you need a cloth dressing on top of that? Well, they want to put a gauze piece over there.
Their idea is to show that that it is touching the patient's skin. That's what they meant. And the problem, what I felt is even under the tegadum, they wanted to put under the tegadum this cloth. So that's going
No,
to,
no, definitely not.
yeah.
Not allowed.
So this cloth itself, it not may not have much of an evidence now, sir.
No, no, no. Not at all. The cloth is no longer sterile once it is out.
Yeah, the line touching the skin may not be a problem. Also, like both we have to maintain the
Correct,
stability
correct.
on that
But
side.
then, where the point of intersection where the CVC line touches the skin and goes inside, that point is extremely important. That is where you would use chlorhexidine dressings, you would use your betadine dressings in the past, and you would also put a tegaderm dressing so that you can see for redness, for swelling, for any discharge in that area, for any signs of inflammation or infection, right, in the CVC. And there, if somebody goes and puts a cloth, what are you going to see then?
Yes.
It doesn't make sense, No. So the answer is no. They can't put a cloth over there.
Right, sir. Another small
And if
controversy.
they insist, ask the surgeons. Surgeons are a breed apart. There are some troubleshooting surgeons and there are some very nice surgeons.
Yes.
But then surgical teams are very nice to work with, provided you don't have one of those funny kind of surgeons, who believe in only creating problems.
Yeah, fortunately, right now we are in that talking level only, sir. Like they will listen. If
Very
we,
nice.
it
So
should be
long
okay.
as they are on a discussion level, they will.
Yeah.
That is the time when you put in your rules and make
Yes, sir.
sure that those are implemented.
Right, sir. Another query which came again 2 days back was usage of hijabs inside the OT. Like this is one of the controversial topic which is going on everywhere. It started here also that some of the students, nursing students who are entering the OT, they wanted to wear a hijab inside. So anything finalized, sir, like based on this? Some court case or
Hijab inside a theater.
yes, sir, operation theater.
No. And will the same hijab also be used outside?
That's what. So that any
No, nothing
policy has
doing
to be
there.
made.
No, then it's not allowed. Sorry, it's not allowed.
No, is it possible to make a policy like a sterile hijab to be made available in the hospital or something like that? One time use.
Sterile hijab. What do you
Yeah,
mean by sterile hijab?
disposable hijabs or something like that.
But then you are anyway using a head cap.
Head cap. Yeah.
You're anyway using a head cap, a buoyant cap, which takes care of the hair. The basic thing is not to show their face and their hair and all that. But then that is anyway being taken care of by the OT dress itself, the OT apparel itself. So on top of that, now I don't understand what is the role of a hijab over there.
Right, sir. Anyway, this question had come, so I thought I wanted to have just one discussion. That's also
No,
fine,
no.
sir.